These cases are just a handful that I pulled together. I think some of them will complement and hopefully reinforce some of the points I made earlier. And then some of them are just to show a few other areas that I think are relevant for the residents and for all of us in radiology, with some scrotal ultrasound and a little bit of pelvic MRI. This case I like to show for the residents in particular. This is a renal transplant patient, and I think all of you can see that there's clearly an abnormal arterial tracing in this kidney transplant. It clearly is arterial, and there is a delayed in the systolic upstroke. There's a very low resistive index, and so I think everyone would recognize this as a very typical pulsus parvis, pulsus tardus waveform. And most of the residents are very quick to say upstream stenosis, which I like for them to say that quickly, but of course that isn't what I would necessarily show them, because that I always like the second one, the second thing in the differential. And so what else is in your differential? If it isn't upstream stenosis, then it's very likely or must be anyone? All right, well, let me show you the next image. So here we see extremely high velocities focally in the cortex. We see a tremendous amount of aliasing. And when one cranks up their velocity scale, they can still minimal flow here, but a tremendous amount of flow with a little bit of reverberation in the surrounding tissues, so-called color Doppler bruit, and this is a AV fistula. These are actually quite common. If you took everybody that had a biopsy and scanned them the next day, you'd be amazed with how many little AV fistulas you find. The reality is that they're usually very small and they regress spontaneously. But on occasion, they can persist and they can contribute to abnormal function of a kidney transplant, and they can certainly be associated with significant hemorrhage if they're large. So keep in mind that AV fistulas as well as upstream arterial stenosis can be associated with low resistive index, pulsus parvis, tardus waveform. With regards to renal artery stenosis, ultrasound of the transplant really allows us to directly interrogate the anastomosis for the area of stenosis. So if I see a downstream pulsus tardus parvis waveform in a transplant, then I'm really going to go in or ask the tech, were you actually able to see the stenosis at the anastomotic site, because that's usually where it's going to be. And so unlike native renal artery stenosis, where it's often very difficult to see the origins of the renal arteries, that isn't the case with renal transplants. So if you have an abnormal waveform, it's nice to be able to directly visualize the stenosis. And at a significant stenosis of the renal artery, the velocity is often very high, usually greater than 2.5 meters per second. And again, you may see a color Doppler bruit where there's vibration in the surrounding tissues. Now, if we only have some downstream findings and we're having a hard time seeing the anastomosis, or if the service isn't really buying that we're seeing stenosis, really MRA has become our study of choice in these patients. And we're doing more and more MRA in liver transplant patients as well, where hepatic artery stenosis is of concern. And I think you can nicely see here that there are actually multiple sites of stenosis. And I think this is really one of the values of MRA in these patients, is because if you correct this stenosis and this stenosis, you may still have problems if you don't correct this iliac stenosis. So in this patient, angioplasty was performed at this site, and this was actually stented. Okay, I'll give everybody just a moment to look at this scan. So we've got the bladder here, obviously. There was some recent instrumentation that explains these few foci of gas. And then here's the abnormality. And then here's a different abnormality. Okay, Well, I emphasized earlier that when you see abnormalities along the posterior superior aspect of the bladder, you want to think of an abnormality related to the urachal remnant. One might say, well, could this possibly be a complicated cyst related to the urachus? This patient did have hematuria, however, and then there was this mass in the omentum. And so you put it all together, and this has to be considered adenocarcinoma with spread of disease to the omentum, and this was confirmed at biopsy. So again, adenocarcinoma is less than 5% of all malignant bladder tumors, yet it accounts for 85% of malignant tumors of the urachus. The location is characteristic. They're often heterogeneous. They may contain calcification, and they're often clinically silent until patients develop hematuria. This was a 32-year-old female. She was 3 days postpartum, and she was ready to go home. All of a sudden, she develops left flank pain and hematuria. So she gets sent down by the OB-GYN service to rule out a kidney stone. Well, it should be quite apparent that the right kidney looks normal and the left does not. And there's abnormal density on this non-contrast enhanced study. This patient had not received any IV contrast or gadolinium for other studies. So we're left with pretty much hemorrhage. So I'll show you a slide later, but we decided to evaluate this patient with MRI. And these are coronal images, T2 pre and post T1. So on the T2s, not particularly specific. Here on the T2s, we see that they're the pre-contrast T1 with fat suppression. There's definitely high signal intensity consistent with the hemorrhage. And then on the post-GAD, there was clearly peripheral enhancement. I mean, this is clearly a ball lesion. This is renal cell carcinoma till proven otherwise, and that's what this was. This was a 3-centimeter stage 1 renal cell carcinoma that, perhaps fortunately for the patient, bled spontaneously while she was in the hospital. Now, this is a problem that's relatively rare, but I think it's an important one that we understand and feel comfortable in dealing with, and that's spontaneous hemorrhage that's associated with renal disease. The largest series out there is a review that McDougall published in 1975, and in that case there were 76 cases of spontaneous hemorrhage. 34% there was an underlying malignant tumor, 24% a benign tumor, and then 18% there was an underlying vascular abnormality, either a fistula or aneurysm. And then you can see the other numbers get quite a bit smaller. Now, Ron Zagorian in 1991 published a series of 9 patients. Half of them had underlying renal cell carcinoma. 2 of them had benign lesions. 1 of them had a MET, and then there were a couple other cases. CT was able to actually demonstrate the underlying tumor in half of those patients, and arteriography was somewhat complementary but not particularly helpful. So in our case, we went with an MRI. Certainly a contrast-enhanced CT, I think, is reasonable. I think if there isn't obvious gross abnormality in the kidney other than the hemorrhage, one can take a wait-and-see approach and bring the patient back in a couple months once the acute hemorrhage is cleared. Or I think it's not unreasonable to try to do an angiogram to see if you can detect neovascularity. These are MRI T2-weighted sequences with fat suppression. The left kidney has a normal appearance on this image. The right kidney, there's a little bit of dilatation of the collecting system. And then centrally, we see this area of really signal void. So when we see blackness on MR, there's only a few things that give us such blackness. One of them is certainly gas. Hemosiderin can be extremely black. And then the third thing we think about is, okay, calcium could be black, okay. Vasculature, okay, so this could be signal void due to high flowing blood. And this is MRA and the delayed. And so we've got a very large right renal AV fistula. This patient actually presented with congestive heart failure and a bruit. And ultrasound was actually the first study we did in this patient looking for renal artery stenosis. And in the lower, well, in this region here, central region, we saw this very huge vascular structure with a to and fro pattern, very high velocity pattern. And then this was actually the angiogram where an attempt was made to embolize this, but ultimately this patient had to have a right nephrectomy. So this is an acquired arterial venous aneurysm, or probably more correctly an arterial venous fistula. This may be the result of trauma, or it may be spontaneous. And in these cases where it's acquired, the shunt is really the dominant feature. These patients will typically present with high output congestive heart failure. They may have a wide pulse pressure. And as in this case, the patient had a very prominent bruit in the right flank. Whereas the last case is a case you may not see every day. This case you'll probably more often see. So we've got a 5-minute film on a excretory urogram. The left kidney collecting system looks reasonable. The cortex looks reasonable. And we've got enhancement of the right kidney without excretion. I can tell you that in another 5-minute film, the cortex became increasingly dense, but there was still not yet excretion on the right. So this pattern is sometimes referred to as persistent, increasingly dense nephrogram. Anyone who owns Hartman's book can look in the back, and there are pages and pages of wonderful differentials for abnormal patterns of enhancement of kidneys during the nephrographic phase on excretory urograms. I think those are important, but as I've alluded to earlier, they may soon not be as important if we get away from doing IVPs. And certainly the differential, one should consider whether or not it's a unilateral or a bilateral process, and I've highlighted in red those which may be unilateral. In the pre-renal category, renal artery stenosis or renal vein thrombosis, and certainly in the post-renal and what we see most commonly, urinary tract obstruction. If it was bilateral, certainly these different renal abnormalities could account for this pattern of enhancement. So this is the delayed image of the bladder in this patient. There's clearly a very large filling defect with irregular margins in the right side of the bladder. Again, this patient had presented with gross hematuria. And actually the main reason why I'm showing this case is because of the CT, which I think has a really interesting enhancement pattern. As you can see, this is pre-contrast, this is post-contrast. So this is tumor, and this is hemorrhage, and then with contrast, the relative density reverses because the tumor is enhancing, and obviously the hemorrhage is not. So it's kind of an interesting case. It's a pretty picture, and sometimes at the end of the day, that's all you want to see. So this was a bladder transitional cell causing right-sided urinary tract obstruction. Okay. How many people have heard of the striated testicle? All right. All right, April 2002. I wrote the paper, please. This is self-promotion. I have a self-promotion moment. After an hour and 45 minutes, I get a little self-promotion now. AJR, April 2002, I wrote up a little series describing a striated testicle pattern. I'm not the first person to describe the striated testicle, but it was a series of 5 patients that I'll talk about in a moment. How many people have seen this appearance in a single testicle? So a unilateral striated testicle. Okay, well, you're going to start seeing them because our machines are getting better and better every day, and we're seeing this more and more. So I think it's important that people be aware of it and feel comfortable dealing with it. So this is a striated appearance, and this actually corresponds to the spaces that run between the groups of seminiferous tubules within the testicles. So there is a anatomic structure or anatomic space that correlates to this striation. And these striations typically radiate from the mediastinum of the testicle. And it's within these spaces that you have your blood vessels. There are certain fibrous elements. And again, these are spaces that separate groups of seminiferous tubules. So when one sees this pattern, obviously one needs to take into account, is the patient symptomatic on this side or not? And in this particular case, the patient was. And there was prominent blood flow along these areas of striation. So this is easy. This is a slam dunk. This is a patient with orchitis. Okay, and then presumably the striations are probably a combination of the prominence of the vasculature as well as probably some edema that accumulates within this space. Okay, now the problem comes in is that if one reviews the literature for various tumors, particularly lymphomas and leukemias, there are descriptions in the literature that these can be infiltrative and can give a striated appearance to the testicle. So I think a lot of people who saw this pattern were concerned, am I missing an infiltrative seminoma? Am I missing a lymphoma or a leukemia of the testicle? But when one looks at the literature, the cases that are in there of leukemia and lymphoma and infiltrative seminoma, almost invariably the testicle is markedly enlarged and there's abnormal color flow signal. So the gist of the paper that I wrote, I had 5 patients who all had this appearance. It was unilateral. I brought everybody back in 1 year, and the pattern remained the same. And when I took a history from all the patients, they all had, a couple of them had a history of orchitis in the past. One of them had a partial orchiectomy on that side. One patient had history of trauma to that testicle. Another patient had an inguinal hernia repair on the contralateral side. So everybody had a history that might provide an explanation for insult to that one testicle. And after a year, every one of the patients remained unchanged, and we felt comfortable that it was very likely and almost certainly fibrosis as the explanation for the unilateral striated appearance. Okay, and again, just to emphasize, an important feature was that the color flow pattern in these patients was either normal, or actually some showed a little bit less flow than the opposite normal side, and the testicles were not enlarged. And in actually a couple of the patients, the testicles were slightly smaller than the opposite side. Okay? So I like to show this case because after the first case, the residents are all geared up. Okay, why is he showing me another case of orchitis? Well, the reality is this patient came in with a very rapid onset of right-sided scrotal pain, and by the time we imaged him, he was feeling much better. So very different story than one would expect for orchitis, and this is a patient who had torsion and detorsion with resulting hyperemia of the involved right testicle. And again, I think it nicely shows again the striated pattern that is associated with the radiation pattern from the mediastinum testis. This was a 19-year-old who came in with right-sided scrotal discomfort and swelling. This is the testicle here. This is a complex right-sided hydrocele here. You can see that there's flow in the periphery or around it, but not within it. So I think whenever I see a 19-year-old, I want to think that he's got something that's not bad. I really want to, I don't like nice young people to have bad diseases. And so I went in and talked to him, and I said, okay, now have you had a history of trauma? He says, well, you know, I was running to the bus the other day, and maybe I bumped my hip or bumped my leg. So then the next thing, so you say, well, maybe there's a history. I don't know how most people in the audience feel, but I think if you're going to do a good job on your scrotal ultrasound patients, it's really critical to go in and do a physical exam. You know, I just think that it simplifies the process tremendously and improves our accuracy if we actually go in and do a physical exam on these patients. I went in on this and this 19-year-old was sitting there. He wasn't in any discomfort. I squeezed his testicle pretty firmly, and he really didn't flinch. There really wasn't any tenderness. So as much as I wanted to call this a hematoma and this blood in the right hemiscrotum, that really wasn't the case. And then when one looks at this and says, okay, there's solid and cystic components, let's take a look at the blood flow. Clearly these solid central components show blood flow. So this is not a hematoma, and this was a mixed germ cell tumor. So those are the 2 points. Again, using color Doppler, it made it 100% certainty that this wasn't a hematoma, and I think it's, again, very important to do good physical examinations, because once you've felt a few testicular neoplasms, you know that they're hard like a rock, and when you feel them, you know that it doesn't really sometimes matter what the ultrasound shows. This was a patient who had some vague scrotal discomfort. This ultrasound was kind of unusual in that at the inferior margin of this testicle, there were multiple microcalcifications. I went in and scanned this myself, and I was pretty convinced that these were actually in the testicular parenchyma rather than being in the tunica. I hadn't seen, before this case, I hadn't seen this type of localized testicular microlithiasis. Certainly there's been a lot written about classic microlithiasis where you see more than 5 microcalcifications on a single image of the testicle. Bill Middleton wrote a very nice paper a couple years ago where he talked about increased risk of cancer in patients who have limited microlithiasis, where you maybe can't see 5 on a single image but clearly have scattered microcalcification. But this was a different pattern. But certainly this was microlithiasis, and so we put this patient in our follow-up routine. At the time, this was about 4 or 5 years ago, we were a little bit more conservative. I think we started with a couple 3-month follow-ups. I think it's reasonable 1 year, maybe 6 months, maybe 1 or 2 6 months. I think, it's kind of up to you and the patient and the urologist that invariably seems to get involved with following these patients. But this is how this gentleman presented, and we followed him for 4.5 years. We did a couple 3 months, a couple 6 months, and then we got into a routine with annual. And then about a month ago, this is how he came in. And I'm not showing it well here, but the area of microlithiasis is actually down here, and now he's got a new tumor. And this was resected, and this was a mixed germ cell tumor, teratoma, embryonal, yolk sac elements. All his tumor markers were negative at surgery. So there aren't a whole lot of these cases in the literature. I think a lot of us maybe for a while weren't sure that we should really be following these because it seemed that we were seeing microlithiasis in patients that were presenting with tumors that were already in the testicle. But I just show this case because I think it's important that we realize that there is more cancer in these patients, and I think it's important that we have a reasonable approach and consistent approach to following these patients and assuring them that if they, that it's reasonable to follow them, and if we find a cancer, we will deal with it when it's found. And there was no evidence for metastatic disease with follow-up imaging on this patient. There's the tumor with color Doppler. One of our fellows recently gave a very nice talk on MRI of the pelvis, and he lent me a few of his slides that I then did a little cutting and pasting. So I've got 3 different patients here. These are MRI sagittal images, T2 weighted. All 3 patients clearly have fibroids. But then in the lower uterine segment of all 3 patients, there are one lesion here, another here, and a third here that have slightly different signal characteristics. Here are the post-gadolinium images on those same 3 images. So this shows some mild enhancement. This shows a large amount of enhancement, and this kind of shows intermediate enhancement. So again, here are the T2 weighted images. Okay, so based on the imaging, someone yell out what this is. Polyp. Okay, correct. This? Submucosal fibroid. Correct. This? Endometrial cancer. Okay? So one can look at this chart and say, oh, yeah, this is kind of nice, this is kind of helpful. And it is kind of nice and helpful, but the caveat is that you really can't reliably tell the polyp from the cancer on MRI. And if you have these type of signal characteristics, the patient's going to need a biopsy for confirmation. But certainly one can suggest or favor one of these diagnoses over another. And clearly the fibroid typically has a different type of pattern, although you can certainly have fibroids that don't always have the typical low signal intensity on the HASTE sequence or the T2 weighted sequences. Okay, this patient presented with some left-sided flank pain. So we've got a large left renal tumor. It's quite heterogeneous. There are some areas of high signal intensity, areas of lower signal intensity, or relative isointensity compared to the normal cortex. So again, high signal intensity, proteinaceous material, sometimes calcifications can give you higher signal, certainly fat, hemorrhage. But the MR is really pathognomonic here, and you've got, this is in phase, out of phase, and at the interfaces between the high signal and the darker signal, there's loss of signal, and this is a chemical fat suppression sequence, and clearly large areas that were high signal are now becoming dark, losing signal. So this is a large renal mass with very large areas of fat. This is an angiomyolipoma. Now, I know after my earlier lecture, someone's saying, well, how certain are you that this isn't a renal cell carcinoma? This is an angiomyolipoma. Okay, anyone what this is? Classic. We've got a fracture, another fracture. Right, extraperitoneal bladder rupture. Here it is on the delayed post-contrast images. None of this was spilling into the peritoneal cavity. This can extend into the groin regions. It can extend quite a bit laterally, but yet this was still not intraperitoneal. And these are almost always associated with spicules of bones from fractures of the anterior pelvic arch, lacerating the bladder. Most of these will close spontaneously with placement of a Foley. If uncomplicated, they're usually limited to the extraperitoneal space, although they can spread to scrotum, perineum, retroperitoneum, etc.
I'd like to start with some terminologies, then we go to pathophysiology of cerebral ischemia, vascular territory, and a list of causes of a stroke in pediatric age group. Transient ischemic attack is a clinical phenomenon. Any acute onset of neurological deficit that would reverse in 24 hours is considered transient ischemic attack. Imaging may be positive. It all depends on what the location of the ischemic insult is. Ischemia is a decreased perfusion without tissue loss or tissue death. Infarction caused by any onset of insult to the brain causing neurological deficit. Very different from stroke. Stroke is a clinical definition. It's a cerebral insult which leaves a permanent deficit. You all know symptoms of a stroke are very varied depending on the location of a stroke, and obviously these are some of the most common presenting symptoms. Causes of a stroke, also very many. Some of them are here. The area that we will be concentrating on today is ischemic strokes. Ischemic strokes are divided into three categories of hyperacute to acute phase, subacute phase, and late phase. The acute phase lasts the first 6 hours, and subacute is from 1 to 4 days, and late phase is basically any time beyond that. In the acute phase, there will be loss of regional perfusion, there will be loss of cerebral glycolysis, and local acidosis. This is usually a cortical-based with very little mass effect. There is a triad of hyperacute, acute stroke. It's a very discrete vascular territory. It's cortical-based with no subcortical involvement, and there will be little to no mass effect. These are two cases on a CT. Most of these cases obviously will be studied by CT first. They come to the emergency room. Almost normal appearing CT, but if you look carefully and follow the density of the cortex around, from approximately here, the density of cortex has disappeared. The same thing here, and another small area here. This is a very early onset of acute to hyperacute stroke. Again, cortical based, but not much of a white matter involvement. This is the same in a child, a baby, and of course, white matter seems to be involved, but that's because myelination has not occurred yet. If you look at the white matter on this side, it's the same density. No mass effect of any significance. This is another case, distinct vascular territory involving cortex of insula and operculum of the frontoparietal lobe. Very well demarcated area of acute, hyperacute stroke. On CT, if you see it to this degree, it's beyond the hyperacute, it's usually acute stroke. How do we see this on MR? Well demarcated, cortical-based lesion with no involvement of the subcortical white matter, a low on T1 weighted images, bright on proton density T2 and FLAIR images. Obviously, the most significant sequence of MR for detecting acute hyperacute stroke is diffusion weighted images that would be very significantly high signal intensity and very clearly defines the territory that has had a stroke. The most significant point to remember here is if you make a diagnosis of early enough in the hyperacute to acute phase, there is a possibility of some neurointerventional procedures to do to correct, at least save some of the brain tissue. This is a patient with a massive left MCA stroke with a complete occlusion of the MCA, very minimal antegrade filling. This demonstrates angiogram with a microcatheter within the thrombosed MCA. This is after partial thrombolysis and patency of the MCA branches. So it's very important that these patients to be detected in the emergency room faster enough, and you can even avoid getting MRI. If patient has symptom, you can actually move them to the angio lab and do thrombolysis. In a significant number of these, there is good improvement. We talk about pathophysiology of stroke in subacute phase. In the subacute phase, edema will settle in. There will be blood-brain barrier disruption, reperfusion, and breakthrough hemorrhage. Edema is a left MCA stroke with a well-demarcated white matter and gray matter involvement, mass effect on the sulci, if you compare it with the opposite side, and the frontal horn. Of other note here is high density of clot within the MCA branch. Again, you see in the subacute phase, the area of a stroke is better defined and subcortical white matter is visualized. Enhancement has very little value in evaluation of strokes, but they do make beautiful images. There is a blood-brain barrier breakdown, as we talked, in the subacute phase, and obviously if you do the infusion, you would see enhancement, usually gyriform. They actually cause more trouble than they are worth because the stroke is very easily detected. When you do enhancement, sometimes the pattern of enhancement may be very strange, and then you end up questioning whether it is a tumor. Clinicians are on top of your head. This doesn't look like a stroke because they haven't seen many, but this is very typical pattern of enhancement. In the subacute phase, we also have reperfusion of the area of stroke and breakthrough hemorrhage. This is significantly more visible on MR. We can identify particular hemorrhages on MR a lot easier. In early phase was difficult because they would ask, can we still heparinize the patient? Can we anticoagulate? I think I usually advise them, yes. If it's just a particular hemorrhages, it's okay. But obviously, in a case like this, you cannot anticoagulate. And this is another very massive area of breakthrough hemorrhage. In the late phase, it's very easy to make the diagnosis. There will be obviously shunting of blood away from the area of a stroke, and there will be volume loss and atrophy will settle in. On CT, obviously, the older this gets, the area of a stroke becomes basically CSF filled space with ex-vasodilatation of the ventricle. In the late phase, you may get clumps of calcification in the area of stroke, and obviously there will be a lack of perfusion. There will be no enhancement in this area. We talk about vascular anatomy. We talk about macrovascular distribution of supratentorial space is anterior, middle, and posterior cerebral arteries. Anterior cerebral artery, all of these vasculatures, they have a macrovascular distribution. Those are large PL vessels that we see, and there is a microvascular distribution these are vasculature that penetrate into the brain either at the base of the brain, and they supply primarily the white matter. Microvascular distribution of the anterior cerebral artery is recurrent artery of Hübner. We will show you some strokes of that, and a whole series of branches of the anterior cerebral artery that is in your handout. Anterior cerebral artery has a very close proximity to the corpus callosum. It immediately wraps around the pericallosal sulci, and it gives a series of branches coming out, supplying the different portions of the brain. And from these, you would have orbitofrontal and frontopolar that they supply the very inferior aspect of the frontal lobe. And then depending on the distribution that they get anterior, middle, and posterior internal frontal branches because they supply the interhemispheric aspect of the hemisphere. And there is arterioparacentral lobule. And the two parietal branches are superior and inferior internal parietal branches. Branches of the anterior cerebral artery exit the interhemispheric fissure, and they anastomose with branches of the MCA that are coming up. This is approximately 1 inch to 1.5 inch lateral to the interhemispheric fissure, and that becomes the watershed zone. These anastomotic pathways are present By reduction of flow in one, it can retrograde fill the other one. This is a patient with ACA stroke on CAT scan in a very acute phase. There is hardly anything visible. On T2 weighted images, you may question a little bit of a settling of a high signal intensity. Obviously, diffusion weighted image, again, the most significant sequence of MR that you can do to identify. This is another stroke of the ACA on the opposite side, very well demarcated. You see involves the cortex of the interhemispheric fissure and travels laterally to the watershed zone. This is basically where it actually stops, and MCA branches, they are lateral to that. Middle cerebral artery, microvascular distribution of it would be the lenticular striae artery that we will talk later about it, and a series of anterior temporal branches, ascending frontal parietal complex, and a series of posterior branches that they have posterior temporal, posterior parietal, and artery of the angular gyrus in the parietal lobe. Middle cerebral artery, when it arises from the internal carotid artery, travels over the tip of the temporal lobe. It makes a turn within the sylvian fissure, and as it branches go superiorly, they make a turn back downward, and they exit the sylvian fissure to go back up. So they have a very undulated course, and they supply, again, the entire operculum of frontoparietal lobe. They extend to the posterior parietal and operculum of the temporal lobe. The strokes of the MCA are probably the most common vascular stroke of the intracranial space. Again, diffusion-weighted images demonstrate the area of a stroke significantly more precise than CAT scan can do, or T2-weighted images, actually. This one clearly demonstrates a complete right MCA stroke, which means the microvascular territory as well as the macrovascular territory of the frontoparietal lobe. There is a complete stroke right on T2, fairly little mass effect because it still is a fairly early stroke. In this patient, I think it's very possible without MRI, we can miss a new stroke in the same territory that patient has had an older stroke. There is a volume loss, there is atrophy of the cortical sulci, but if you look, there may be a little bit of a mass effect. Obviously, this would be very clearly visible as an additional small area of a stroke in a territory that has a stroke already. This is a FLAIR image. You can see the thickening of the cortex in that location, a new stroke of the right MCA over an older stroke. Posterior cerebral artery arises from the tip of the basilar artery. It wraps around the midbrain. So we'd have a P1 segment or a peduncular segment. This is anterior to the cerebral peduncles. It wraps around the midbrain and cerebral peduncles, so it had an ambient segment and reaches posteriorly to the quadrigeminal cistern. We'll talk about some of the branches here. Posterior cerebral artery supplies most of the temporal lobe along its medial aspect and along the floor of the midcranial fossa. It supplies the entire occipital lobe and extends anteriorly via anastomotic pathways to supply a large section of the parietal lobe. In this location, when you look, this is exactly where the posterior cerebral artery wraps around the midbrain. So you will have the pons and cerebral peduncle spaced in here, and quadrigeminal cistern would be posteriorly here. Stroke of the PCA, it can be complete. That in that case would involve the thalamus as well as the medial aspect of the temporal lobe and the entire occipital lobe. As you see, well visualized distribution. Diffusion-weighted images, again, demonstrates a very large area of high signal. Again, if you look at on T1, there is barely anything appreciable in this location. We talk about vasculature of the posterior fossa, superior cerebellar artery. It has two groups of branches, hemispheric branches and superior vermian branches. Very simple anatomy. Superior cerebral artery arises from basilar artery. It wraps around the midbrain again, very similar in distribution and pattern, actually the course, course to the posterior cerebral artery. It has a peduncular segment, ambient segment, and quadrigeminal segment, And as it reaches the dorsal aspect of the pons, it gives a series of branches that drape directly over the cerebellum and vermis. So these are the hemispheric branches, and these are the vermian branches. All of these branches go around the cerebellum, and they anastomose with branches of posterior inferior cerebellar artery that cover the bottom half of the cerebellum and coming up. So they're basically hugging the cerebellum from above and below. The strokes of the superior cerebellar artery are immediately under the tentorium, are well demarcated, and you see this area of stroke is the same as this area. And most of these vasculature actually stops at the level of the greater horizontal fissure, and at this level they anastomose with branches of pica. This is another smaller stroke of the superior cerebellar artery, immediately under the tentorium. You can see on the surface of the cerebellum, the fusion-weighted image again is positive, and on sagittal images you can see the area of a stroke. Again, above the greater horizontal fissure in distribution of the superior cerebellar artery. We talk about posterior inferior cerebellar artery, pica. Arises from the vertebral artery, before it meets the other vertebral artery. It wraps around the medulla. It comes posteriorly. It goes to the pretonsillar or retromedullary fissure and travels superiorly. It wraps around the dome of the cerebellar tonsil. At this point, it's called the choroidal point. It gives a series of perforated branches that supplies the choroid plexus of the fourth ventricle. For that reason, it's called choroidal point. It wraps around the posterior aspect of the tonsil, and when it reaches inferiorly, it gives two series of branches, vermian branches and hemispheric branches. Vermian branches obviously are further into the skull from the inner table of the skull, and they will be projecting up here. These are inferior vermian branches, and they anastomose with superior vermian branches arising from the superior cerebellar artery. The hemispheric branches wrap around the inferior aspect of the cerebellum, and as you see in this image, they are traveling upward, and at the level of greater horizontal fissure, in this case, obviously, a specimen, they are going beyond it, but usually they anastomose with branches of the hemispheric branches of the superior cerebellar artery. They are very difficult to detect. The strokes of the pica are very, very difficult to detect on CT, especially if patient is not cooperative, which many of these with this kind of a stroke, they won't be very cooperative. So MR is very, very helpful here. CT has a significant amount of artifact in the posterior fossa if patient is not cooperating very well, and especially if these strokes are small. Obviously, as you can see here, like most strokes of the posterior fossa or vertebrobasilar system, there is usually more than one stroke. If you find one stroke, you should look for an additional stroke, either old or new. In this patient has a very large stroke of pica involving the entire territory of pica, as well as a stroke in the opposite side. The enhancement in this case, again, I don't recall exactly why this patient was infused, but it's possible that maybe they were concerned about tumor at one point when we were doing the study. Again, you can look at the inferior half of it. It can involve the tonsil, and obviously when mass effect occur, it can cause herniation of the tonsils into the foramen magnum. We talk about microvascular distribution. Anterior cerebral artery microvascular distribution is recurrent artery of Hubner. MCA, microvascular would be lenticular striae artery. Posterior cerebral artery would have the thalamoperforators, and internal carotid artery, it has anterior choroidal artery, which is also a microvascular. This is a typical example of an acute lacunar infarct in the distribution of the lenticular striae artery. Diffusion weighted images are high in signal intensity. Obviously, T2 weighted images also demonstrates it very well. These strokes in acute phase are larger, like most stroke, and in a subacute phase, and they produce mass effect. But however, you really cannot estimate the age of these strokes on CAT scan. MR is the best technique to detect whether there is a acute stroke or not in a lacunar form. Many of these patients, obviously, if this is the only lesion that you find, it may be easy. But if patient has many old strokes, you can miss an acute stroke on CT, but diffusion-weighted images will tell you that there's a new stroke. So this is a microvascular stroke of the MCA. This one, again, ACA, that was recurrent artery of Hubner. These are microvasculature of the middle cerebral artery, lenticular striae arteries. They have an S-shaped configuration. They arise from the M1. They move medially, laterally, and eventually back medially. They all parallel one another, and this is anterior choroidal artery as well. Typical course of a stroke, very similar to the distribution of the vessel of lenticular striae artery stroke of MCA, positive on diffusion-weighted images. This is a very large MCA stroke. This looks significantly larger in distribution than a single microvascular stroke of lenticular striae. It could happen at times that when there is a plaque in the M1 segment, the plaque can bleed and dissect and cause a massive stroke of the MCA. Sometimes a clot can be lodged in the MCA, and a stroke of the MCA lenticular striae arteries can occur, and clot can break up and move distally and end up with a series of collection of MCA strokes. This is an old left lacunar infarct of the right basal ganglion with hemosiderin-laden wall. It's a scar of an old hemorrhagic lacunar stroke. This is a very interesting case. Distribution is very difficult to tell exactly what distribution it is. It's not quiet thalamic region, and it's not really quiet basal ganglion in a perfect example. And also it extends, if you look at it from here, it extends all the way laterally and deep into the temporal lobe. This is a stroke, lacunar stroke of anterior choroidal artery after aneurysm clipping of the anterior choroidal or artery aneurysm. Very rare type of a stroke. We see these sometimes in cases of interventional cases. Of other microvascular strokes, these are from the basilar artery, perforator branches of the basilar artery. They supply the brain parenchyma in the pons region. These strokes, again, for diagnosis, the studies are the same, MR or CAT scan. Again, in the posterior fossa, they are much more difficult to see on CAT scan than it is on MR. These are well demarcated, like most lacunar infarcts. They are perfectly in the midline. They do not cross the midline. So this will be different if you had central pontine myelolysis or if there was a tumor. They do follow vascular territories. We talk about boundary zone strokes. These are deep white matter and watershed areas of a stroke. These are strokes that sometimes you look at the study when you're new in the area and you wonder, what vascular territory am I looking at? Well, this is very typical. It's not anterior cerebral artery. The cortex of the interhemispheric fissure is maintained. It's not MCA because cortex of the frontoparietal lobe is not involved. You see this parallel line following the watershed zone. These are from deep perforator branches, and it's the most common cause of this type of stroke is lesion within the carotid artery in the neck. So in this case, MRA demonstrates very extensive vascularity of the vertebrobasilar system, but there is bilateral occlusion of the internal carotid arteries, causing watershed strokes. These are the most distal branches, very simple to plumbing. The farther away from the source you go, the lower the pressure is. So when the pressure in the internal carotid artery drops, the perfusion, the area that loses the maximum perfusion is the watershed zone. These are the very end vessels. So this is a case of moyamoya with extensive watershed zone strokes. Moyamoya is actually the description, and it's a juvenile carotid occlusion in a progressive fashion. In type 1 of it, it's usually familiar and is more common in Japan. And in the Western Hemisphere is usually in the NF, Sturge-Weber or polyarthritis, and RT can cause moya. So it's not just that puff of smoke that we talk about moya cases. Stroke in pediatrics, I just give you a list of strokes. In pediatrics, the study of the pediatric strokes is very similar to adults. CT, usually, because it's so quick to obtain. Obviously, MR has a very high value in evaluating. There are two groups of strokes in pediatrics: thrombotic causes and embolic causes. The most common cause of stroke in pediatric age groups are actually thrombotic causes. And this includes a vascular injury, sickle cell disease, trauma, radiation therapy, chemotherapy, and coagulopathy, specifically protein C and D deficiencies, and antithrombin 3 or heparin cofactor deficiency. Of other causes of thrombotic causes of stroke in pediatrics, you have it in your handout. And the embolic causes of stroke, there are numerous, but it seems today, because of extensive interventional procedures that is performed on kids, the actually complication from interventional is becoming number one cause of stroke in embolic stroke in pediatric age group. Thank you.
White matter disease is two diseases. Talking about demyelinating disease or dysmyelinating disease. We're primarily going to be talking about demyelinating disease today, in which normally formed myelin is destroyed. Either primary, in which the myelin sheath itself is destroyed with preservation of the other neural structures, or a secondary process in which the destruction of the myelin is due to another disease process. Dysmyelinating disease, in contrast, is one in which the myelin formation is either absent, delayed, or abnormal from the start. Generally, these are biochemical or enzymatic defects. Before we begin talking about white matter disease per se, I want to talk about white matter disease variants, or normal variants that can mimic white matter disease. The most common of these is the Virchow-Robin spaces, which you're all familiar with. These are dilated perivascular spaces, characteristically isointense to the CSF on all imaging sequences, and this will be our most important diagnostic point. They can be very large, and this can confuse people, especially at the basal ganglion. They can be up to 1 centimeter in size. Here you see multiple perivascular spaces. In addition, there's some bright signal from a true lacunar infarct on the FLAIR image, and you can see the difference where all of these disappear, whereas the one ependymaitis granularis is a cap of high signal anterior to the frontal horn. It's a very common finding on FLAIR images. This represents an area of myelin pallor, or thinning of the ependema around the ventricle, which allows a little bit more fluid permeability and therefore increased signal. It's a very similar finding to what we can see in elderly patients or advancing age patients, perhaps, where you get a thin rim of high signal. This is not a transependymal spread, but rather just a thinning of the ependema. And the margin that you see on this, as opposed to transependymal spread of fluid, is usually less regular than what you see with hydrocephalus. The other normal variations that we see are what used to be called UBOs, unidentified bright objects. Small, nonspecific white matter abnormalities, also known as white matter changes of aging, normal age-related changes. I don't like the normal age-related changes as much because obviously we can't expect to see a certain amount. They are seen, however, with increasing frequency with age. They're also seen with increased incidence in migraine patients. And in contrast to the small vessel disease that we'll talk about later, when you see it in migraine, they're usually more peripheral, more subcortical. The pathology in these is variable. Usually we don't obviously have pathology directly, but when there are posts on these patients, you can sometimes see areas of gliosis where you see these white matter changes, areas that are suggestive of ischemic change, focal demyelination, and at times no pathology at all is seen where there's clearly is a lesion by radiography. And you've all seen these. So let's move on to multiple sclerosis. Multiple sclerosis is pretty much what white matter disease is. So if we take ischemia and white matter and multiple sclerosis, that pretty much is going to be most of our cases of white matter disease. It's a disease of uncertain etiology, believed to be either an immune-mediated myelinoclastic process or perhaps due to an indolent viral infection. About 85% of them have the classic relapsing remitting course, with another 20% having the more chronic progressive form without the characteristic clinical relapses. 95% of them will occur between the ages of 18 and 50. So this is really the age group where we're going to see. They do occur in children, they do occur in older patients, but this is where we're going to be looking for multiple sclerosis as a diagnosis. And peak around the age 30, and as you probably well know, a female predominance. A single episode of multiple sclerosis may be extremely difficult to differentiate from acute disseminated encephalomyelitis, and we'll come back and talk about that later on. But remember that a single monophasic course is very difficult to make this differential, and keep that in the back of your mind. Involvement of the U fibers or the immediate subcortical associative fibers or the corpus callosum is very suggestive of multiple sclerosis versus small vessel disease, which in the 40, 50-year age range is going to be a problem for us in some cases. Lesions adjacent to the temporal horn or the fourth ventricle are very suggestive of multiple sclerosis, again, instead of small vessel disease. Remember, demyelinative lesions can be seen anywhere there's myelin, and this includes the cortex, basal ganglion, and the subcortical U fibers. So we don't normally think about multiple sclerosis in the cortex, but in fact 7 to 10% of plaques will involve the cortex where there is some myelin. Common locations, again, in the periventricular white matter is our classic location, and some posterior fossa locations I'll show you in a minute, make us a little more comfortable with the diagnosis. CT can be very difficult. CT, you don't get the well-defined discrete lesions in general that you see by MR. They're hypodense. You can occasionally see enhancement of lesions by CT, but there's much less sensitivity to contrast enhancement on CT, and so it's rare to see any significant enhancement by CT. Generally, what you see is just this more ill-defined, patchy areas of hypodensity. The MR appearance is much more classic. The true classic appearance with the periventricular, perpendicularly oriented lesions, but in general, a periventricular preponderance of the lesions that we do see. They're usually hyperintense on the flare in T2 or proton density in T2. Occasionally, you'll see a slight hypointense rim around on the T2-weighted images, and occasionally you'll see hyperintense lesions on the T1-weighted images. When you study the white matter adjacent to these lesions, or what appears to be normal white matter, a number of studies, including trials that looked at the T1 and T2 relaxation times, as well as magnetization transfer of these areas, have shown that, in fact, even normal appearing white matter may have normal myelination. And the Dawson fingers, the classic description of multiple sclerosis is, again, these perpendicular lesions basically represent a demyelination extending along the medullary veins running into the ventricle, but you end up with a plaque that runs perpendicular to the ventricle by and large. Again, as we mentioned earlier, the involvement of the U fibers, these immediate subcortical associative fibers, is very suggestive of diagnosis of multiple sclerosis. Lesions in the corpus callosum, I don't have a nice example, but lesions in the brachium pontis or the trigeminal entry zone are very suggestive of multiple sclerosis. And here another example, multiple bilateral. This is a very uncommon location for small vessel disease. Enhancement, when you see it, may correlate with disease activity and transient breakdown of the blood-brain barrier. Enhancement in small plaques is generally homogeneous enhancement of the whole plaque, whereas in larger plaques, you see this enhancement at the leading edge of the demyelination. Multiple lesions may coalesce to form a single large confluent lesion, and solitary lesions may have a very mass-like appearance, and when you have a single lesion, may be mistaken for a mass. This is one with a more mass-like appearance, actually two lesions, but a large dominant lesion with a smaller associated lesion here. Here you can see some peripheral enhancement of both of these lesions. This is a patient with multiple sclerosis, and in fact, this one was not a diagnostic dilemma because on the lower cuts there were in fact more characteristic periventricular lesions, but you can see with a single lesion, you can start thinking about abscess, tumor, etc. And here's a nicer example of that. If you see just the one ring enhancing lesion, you can start thinking about an abscess or a metastatic lesion. In this case, though, very little, if any, edema around it that you might expect to see with those lesions. Involvement in the spine is most common in the Cervical spine, about 60% of MS lesions in the spine are in the cervical region. They're generally peripheral in the spine, involving white matter tracts, and they may mimic a cord tumor. You may see expansion of the cord, edema of the cord, and intense enhancement of these lesions, and for all the world looking like a cord tumor. And I think Ed already showed you that in the last or talk before last. There are some variants of multiple sclerosis. The one I'm going to show you here is the so-called Marburg variant. It's a severe form of multiple sclerosis with a rapid, progressive course, diffuse white matter lesions, frequently with a fatal progression, and you can see just the diffuse involvement bilaterally, intense enhancement bilaterally. You can have confluent lesions involving a majority of the white matter, and as here, the enhancement is often extremely prominent. What you have here is a relative lack of any surrounding edema, mass effect. There is some edema over here, and in fact, I think there was a secondary infarct here. But by and large, we've got multiple areas of intense enhancement, and I'll go back for a second, with a relative lack of mass effect here. There aren't a lot of processes with diffuse, bilateral, intense enhancement like this. We can think about some things like glioblastomas on both sides. They generally don't occur in multiple locations, generally have more mass effect. It's a terrible look. It's a terrible looking picture, but when you start thinking about it, the differential that you can come up with is actually very limited. You end up with some kind of a white matter process here, and as I've already mentioned, some kind of a white matter process usually brings us back to multiple sclerosis as the most likely culprit. Okay. Having said that, let's move on to the other possibilities for white matter disease. The other things are predominantly secondary. They're due to another disease process going on. We'll begin with the vascular causes. And small vessel disease is the second major cause, and probably the first most common cause of white matter abnormalities, certainly the most common cause in adults. Generally involving small perforating branches of either the deep branches at the base of the brain or cortical branches perforating in at the gray-white junction. You may see enhancement in the subacute phase, often a punctate focal area of homogeneous enhancement, and most common in the patients that we would expect, in hypertensive patients or diabetic patients. You may see diffusion-weighted abnormalities. You may see a bright focus of restricted diffusion with an acute lacunar infarct. White matter in general is more susceptible to ischemic change than the gray matter because there's a more limited blood supply. There's usually not the collateral supply that we have to the gray matter, and that's the reason that hypertensives and diabetics are more susceptible to these small vessel type changes. You can see here the more peripheral location than the MS that we saw more adjacent to the ventricle. Subcortical eufibers that we saw in the multiple sclerosis and the corpus callosum are usually spared, although remember when you get a severe or late case or progressed case, you can see changes just about anywhere. There are ischemic syndromes, including Binswanger's disease or subcortical arteriosclerotic encephalopathy. They do exist, but their clinical symptoms, remember, and by and large, clinicians will not thank you if you use these terms in describing white matter disease just because they imply a clinical syndrome and you don't know. There's very little correlation often with what we see radiographically and what they see clinically. So the preferred term is small vessel disease, but be aware that there are in fact syndromes with diffuse small vessel disease and clinical entities that go along with those. Multi-infarct dementia, similarly, it's a clinical diagnosis, obviously, rather than a radiographic one. Vasculopathies such as CADASIL may also mimic these findings. CADASIL is a inherited arteriopathy with what presents with what looks like very severe small vessel disease, what is in fact very severe small vessel disease, but in patients who don't have significant risk factors. So you see a 40-year-old man with this picture who's not a diabetic and not a hypertensive. Think about the possibility of an underlying arteriopathy. And they present with very unusual symptoms, mood disorders, dementia are some of the kinds of things that you see in a picture like this. Think about the possibility of an underlying arteriopathy as the etiology for this severe small vessel disease picture. Generally without the enhancement and without the, at least early on, without the mass effect, without the atrophy that we see with multiple sclerosis. Ischemia can also be venous. Venous thrombosis may present as ischemia with isolated patchy areas of white matter abnormality. And if you're not suspecting this, white matter disease isn't the first thing that you think of when looking at it. Generally bilateral and in a non-vascular distribution, which is the hallmark for venous disease. Clinically, the hallmark is atypical symptoms in a patient at risk. So a post-pregnancy, pregnant woman, woman on birth control, patients with malignancies, patients who have risk for thrombotic disease. By CT, we know we look for the hyperdense CT sign on the hyperdense sinus sign on the non-infused CT, and the empty delta sign, which I'll show you a little later on the post-contrast studies. And MRV is now our study of choice if there's any suspicion for sinus thrombosis. Although, in fact, I think in most cases, just looking at the MRI images, you can look for the absence of the flow void or look for the enhancement pattern of the post-infused studies. So the MRV itself is often not necessary. And in this case, this slide was older, but it was such a nice depiction of the complete absence of the spirosagital sinus that clearly our gold standard is still the angiogram if we have any concern after doing the MR. Vasculitis may be infectious, which we'll talk about in our infection talk later, due to bacterial, viral, or fungal disease, and may present as isolated white matter disease. Non-infectious causes of vasculitis, also keep in mind, patients who come in with a history of SLE, rheumatoid arthritis, are prone to small vessel white matter changes. Also drug abuse and radiation. The radiation we'll come back to and talk about separately. And all of these may result in patchy areas of white matter abnormality, usually also with areas of cortical ischemia. So it's usually not an isolated white matter abnormality, but it can be, and so we have to include this in our differential for white matter changes. Here's a small focal area of white matter abnormality in a patient with the viral encephalitis. Here's one entirely limited to the white matter. These were the only findings, these little patchy areas in the periatrial white matter. Oops, in case you couldn't see those. And angiogram showing vasculitic changes in a branch of the middle cerebral artery here. There's a variety of infectious processes that may present as white matter disease. However, of these, Lyme disease, the HIV virus, and PML are the only processes that are limited only to the white matter, and so we'll talk about other infections later. Here I just want to talk about the ones that are white matter diseases predominantly. While atrophy is the most common finding with the HIV infection of the brain, white matter lesions can be seen. They may be seen as diffuse areas of patchy white matter abnormality or discrete, more focal areas. They're generally relatively poorly defined lesions, usually with no mass effect and usually with no enhancement. By CT, this is a patient with AIDS, HIV positive, and these are changes of HIV virus, although remember that most patients with HIV virus will also be infected with CMV. It may be difficult to separate those two. They can be seen as small punctate foci. This is not the classic picture that we associate with AIDS or with HIV virus, but it can be seen with just small focal areas of white matter. This is the more common appearance with diffuse kind of flocculent areas of increased signal intensity in the periventricular white matter, ill-defined margins. Let's move on. Lyme disease. Lyme disease isn't a common disease, but on the other hand, it's one of those ones where we can come up with a diagnosis and suggest it where it wasn't otherwise suspected. And I'll go over a little more details of it in the infection talk later, but this can be seen as isolated periventricular and subcortical white matter dots. We may not be able to tell radiographically the differential in this disease from multiple sclerosis or acute disseminated encephalomyelitis. We just need to have a clinical index of suspicion in the appropriate locale and in the appropriate season. And again, very difficult. No way to tell that we're not looking at either small vessel disease or MS in the appropriate patient. But you need to, this is one of those ones, how often do radiologists say you need clinical information to go with this if you're going to make a diagnosis like this. And finally, PML is the other infectious process limited to the white matter. In immunocompromised patients, most commonly patients with AIDS, but also transplant patients and lymphomas, again, keep it in mind in the appropriate clinical setting. This is one that causes destruction of the oligodendrocytes and therefore an inability to produce or replace myelin normally. Can be either frontally or parieto-occipital. The classic description is parieto-occipital, but in fact we see it throughout the brain, frontally, parieto-occipital, as well as in the posterior fossa. Early on, it's seen as a subcortical white matter disease, often in just one location with a scalloped outer margin, usually very distinct edges. In contrast to the AIDS virus we just saw, you can see how distinct the margins are here. And here's a more classic parieto-occipital appearance. Usually bilateral, but usually asymmetric. Hemorrhage is very rare with PML in the brain, although it can occur. Other viral encephalitides may all cause white matter disease in certain cases. bacterial, fungal, parasitic, granulomatous disease. They all can cause white matter disease, but more commonly all of these will have both white matter and gray matter disease and be more suggestive of an infectious process. Hemorrhage and necrosis are also more common with some of the, especially the bacterial and fungal, and we'll go through that with our infection talk later. Just very briefly, a couple of examples of infectious processes with white matter, and you can see that there's in fact cortical involvement also in this enterovirus infection. Toxoplasmosis, pre and post treatment. There's a lesion, basal ganglion. Most of what we're seeing is vasogenic edema, but it appears as a white matter abnormality when we're coming up with our differential. And sarcoidosis, and I never know where to put sarcoid in the talk as far as infection otherwise, but it can occur as either punctate focal areas of increased signal intensity in the white matter or more patchy periventricular areas of abnormality. ADEM, or acute disseminated encephalomyelitis, is a fairly frequent disease in the white matter differential lesion. It's a post-viral immune response. It may in fact be more frequent than we see, that is, some of these may be subclinical. Classically, 1 to 3 weeks after a viral infection or vaccination. Actually, a wide variety of viruses, just about any virus that affects the human host, can cause a post-infectious immune response, although it was classically described with the measles and mumps viruses. Clinically presents with an acute onset and a monophasic course, in contrast to multiple sclerosis, although again, with the first episode of a neurologic symptom, it may be impossible to tell whether we're looking at multiple sclerosis with its first neurologic symptom or a post-infectious etiology. New lesions can appear as older lesions disappear. However, we shouldn't see new lesions continuing to appear beyond 6 months after the initial presentation. And there is a rapidly progressive variant, acute hemorrhagic leukoencephalitis, which may be fatal within a week of onset. Here's a patient with a classic posterior periatrial lesions. Again, multifocal, usually asymmetric in the subcortical or deep white matter, occasionally in the brainstem or cerebellum, most common supratentorially. Very uncommon to have mass effect and uncommon to have any contrast enhancement. When we do see it, it's usually, again, a very faint peripheral rim at the leading edge of the demyelination. Radiation injury is another significant cause of white matter abnormality. Again, it helps to have a clinical history suggestive of this, but in many cases the possibilities are going to be obvious. That is, there's going to be evidence of previous surgery for a brain tumor, or there's going to be evidence of a vascular malformation that's been treated, and then we can look at the white matter and say, maybe this is related to the original disease and the treatment thereof. Radiation injury in the acute phase represents something during the course of therapy or soon after therapy, and represents a little focal edema, usually not imaged, and generally called, when it is imaged, it's usually incidental. That is, the patient's being worked up for some other reason, and you notice some white matter changes. These are transient and will go away. Same thing for the early delayed phase. In the first 1 to 2 months after therapy, you can see focal lesions anywhere in the brain that's within the port, and within the port is an important part here. We need to know what was treated when we're going to use this in our differential, but this represents some transient edema. In the late phase, we have two different processes that we can see. One is the diffuse radiation injury, which represents a vasculopathy due to the radiation therapy. And this is either patchy or confluent areas of white matter abnormality, and these are in fact the equivalent of small vessel disease. They are a disease of the small vessels secondary to the radiation, and the pathology is related to vascular destruction and demyelination secondary to that. Radiation necrosis, on the other hand, generally presents more than a year after therapy. Again, it has to be within the port, so it's generally going to be at the periphery of the lesion if you see, for instance, a tumor bed or a tumor resection site. You have mass-like lesions. They enhance, they have edema, occasionally they'll hemorrhage, and the problem is that it can be very difficult to tell these from residual or recurrent tumor. Here's a focal radiation change. I didn't show you the next image, which actually shows what's left of a small AVM, but this is within the port region of a small AVM just adjacent to the frontal horn on someone who had been finished or had radiation 3 months prior to this study. And this is a woman who had whole brain radiation for breast cancer, and here you see just diffuse small vessel disease kinds of changes, but severe in a relatively young woman. I think this woman was in her 50s. We don't expect to see these kinds of changes from small vessel disease, barring some intervening therapy. In the late stage, it'll show diffuse atrophy also. That was a little earlier than we see that. This is a patient who had an oligodendroglioma resected several years, or 2 years prior, and has this focal area of enhancement that presented about 4 or 5 months after the end of radiation therapy, so about a year and a half after they started radiation therapy. And at this point, this has remained the same for about 16 months. And I don't have surgical or pathologic proof on this one, but this is staying the same. It's not increasing in size. There's no edema, and it's 16 months after, and this is presumed to represent radiation necrosis rather than residual or recurrent tumor. This is a patient after resection of a anaplastic astrocytoma with 2 focal areas of intense enhancement. Not a lot of mass effect, although you do see a little bit of edema around this right temporal lobe lesion, and this is biopsy-proved radiation necrosis. But you can see the difficulty in saying that this is not, in fact, tumor rather than radiation necrosis. Just briefly, you're probably aware there are radiation necrosis, a difficult issue. I'm not going to talk about the PET or the SPECT imaging of that. The magnetic resonance spectroscopy will show changes with tumor as opposed to radiation necrosis, and perfusion MR is now showing some promise in showing that also in showing the increased cerebral blood flow with cerebral blood volume, with tumors as opposed to radiation necrosis. PRES, or posterior reversible encephalopathy syndrome, represent reversible causes of white matter abnormality. These most likely represent a failure of autoregulation of small vessels with secondary white matter edema. These are reversible if appreciated early on. If not, they can progress to ischemic change. And one of the examples of these is chemotherapy. I got a long list of chemotherapeutic agents here that have been described with PRES syndrome. I'm not going to go through all of them, but I think keep in the back of your mind that more important than remembering exactly which these are, a patient on chemotherapy, consider the possibility. Because as I go through these lists, I get patients who come in, they have white matter abnormalities. They're not on the list, they haven't been described, but I have to suspect that, in fact, there are chemotherapeutic agents that have not yet been described that may also cause this. They're generally focal and asymmetric, most commonly posteriorly, most commonly sparing the subcortical U fibers and the corpus callosum. Again, a high index of suspicion in a patient on chemotherapy. The last one is not really a white matter, but it's just interesting when we're talking about chemotherapy. The L-asparaginase is used in leukemia. It can cause a sinus thrombosis, which then will go back down the same pathway we already talked about, sinus thrombosis, venous infarction, and white matter abnormalities secondary to the venous ischemia. Here's an example of patient cyclosporin. They can occur within a few days of therapy. Posteriorly is the most common location. Young woman on methotrexate for an osteosarcoma. You can see the areas of white matter abnormality in the parietal region. Malignant hypertension is another classic example of the reversible ischemic changes, most commonly posterior, but they can occur anywhere at the gray-white junction. When you see supratentorial edema in combination with cerebellar or brainstem edema, you should think about the possibility. There's a relatively subtle one with some white matter changes in the frontal lobe. On MR, more obvious the changes at the watershed zones, anterior middle and middle posterior. Oops. Eclampsia probably is a similar mechanism to hypertensive encephalopathy, although there's an alternate hypothesis that this may be related to a release of platelet factors and increased permeability of the capillaries. It's most commonly in the white matter of the parieto-occipital regions, generally a symmetric process, and again, may be reversible if appreciated and treated early. Here's a woman, an eclamptic woman, diffuse changes. By day 6 with treatment, you can see that they're significantly improved, and by day 23, an MRI is completely normal. Osmotic myelinolysis, what was known as central pontine myelinolysis, we appreciate now that in fact it's not limited to the pons, and so the osmotic myelinolysis is a preferred terminology. Classically, the rapid correction of hyponatremia, but in fact, almost a wide variety of metabolic abnormalities as well as malnutrition and renal failure may lead to these white matter changes. They can occur not just in the pons I mentioned, but anywhere in the deep brain structures. This is the classic appearance, however, though, with the central white matter change and the rim of preserved tissue around it. Differential we're going to think about here is ischemic changes in the pons, multiple sclerosis, a single large lesion, usually not quite as symmetric as this, and a brain tumor. Often, not usually a thing, but a glioma in the pons may have a similar appearance. Generally, gliomas are a tumor of children, as we'll see later, and so that shouldn't be a major differential there. We're not going to go through dysmyelinating diseases at any great length, but I just want you to be aware that dysmyelinating diseases that we think of in general as diseases of children do in fact occur in adults also. All of these have can have adult presentations, although far less common than the pediatric presentation. This is a 21-year-old with adrenal leukodystrophy. On CT, you see the biparietal areas of hypodensity, classic appearing T2-weighted hyperintense signal, enhancement, fairly intense enhancement, but at the peripheral edge of the demyelination. Briefly, our differential diagnosis when we see the unidentified bright objects, the age-related changes, the Virchow-Robin spaces, multiple sclerosis versus ischemic changes. Think about the possibility of vasculitis, infection, viral, bacterial, fungal, Lyme disease in the appropriate age and, in the appropriate locale and the appropriate season, and we'll talk about that in our infection talk, and ADEM. In an adult, less than 50, think about MS, greater than 40, and I left a little overlap zone there where it can be difficult and we need some help. Early involvement of the U fibers suggests multiple sclerosis. Remember the age-related changes, isointensinol sequences, those usually are not a difficult dilemma. The onset of clinical symptoms, acute onset, think about infectious, inflammatory process, perhaps a vasculitis, relapsing course, think about the possibility of multiple sclerosis. And then clinical information. In immune-compromised patients, we think about opportunistic infections, we think about PML, lymphoma, AIDS virus, recent illnesses, possibility of an acute disseminated encephalomyelitis, press, if there's anything that should suggest this, patient's hypertensive, patient pregnant, we usually are aware of that one. That one's not usually a dilemma, but given a course in an unnatural setting, like in a board situation, you might want to ask that question. And then past medical history, their travel history, any concurrent illness, is there a history of hypertension? Again, the kinds of things that we should expect to get, but clearly we frequently don't get. Okay, first question looking at brain tumors sounds like a stupid one, but first of all, are we sure it is a tumor? One of the things that we see frequently in our hospital is patients coming in, referred in for a biopsy of a brain tumor, and it's kind of like, where's the tumor? There's many lesions that will mimic tumor. Abscess is clearly one of these. You can have ring-enhancing lesions. In this case, one would certainly think about the possibility of an abscess just by location adjacent to the sinus. Here's another one that came in, 3 weeks ago, I think, for resection of a brain tumor. I could put just the pre and post up here. You see this very irregular-looking lesion. This was taken to the operating room for resection and, in fact, turned out to be an abscess. And, in fact, they still don't know what the abscess is. That is, they got pus out of it, but they still haven't been able to recover a bug. I showed you this one with the white matter talk. MS lesions can look like tumors. Here's a patient with increased signal intensity in the medial temporal lobe. And this one is, in fact, sarcoidosis, and on the post-infusion, you actually see the enhancement going out to the leptomeningeal surface, making that diagnosis, or at least making you suspicious that we're not, in fact, looking at a tumor there. But here's the one I just showed you, the coronal images. This is a different patient, and this one, in fact, is a tumor here. Very similar appearances. And finally, the one that's probably once every 3 or 4 months, we'll get something like this coming in for biopsy of brain tumor, this increased signal in the temporal lobe, middle temporal lobe. On the contrast images, you start to see a gyroform appearance to the surface and this enhancing infarct. And the infarct is one that often is mistaken. You can get peripheral enhancement, you can get edema and mass effect around it. And like I said, pretty regularly, every 3 or 4 months, we'll see a infarct come in as a purported brain tumor. Okay, those aren't tumors. Let's talk about primary brain tumors. We're going to talk just about the intraaxial tumors today. Clearly, there's a whole variety of tumors that occur intracranially, but not intraaxial. We just can't cover everything right now. Intraaxial tumors, the gliomas, and a couple of other common intracranial tumors we need to consider also. We're going to try and use a pattern approach here. It isn't that difficult to come up with a relatively short list of likely possibilities, usually 2 or 3. And if we start with intra versus extraaxial, as we just said, especially with the ability to use MR now, that's not usually a difficulty. CT, it was occasionally difficult to tell over the high convexities or at the base of the skull whether things were intra or extraaxial. Generally with MR, that's not a problem. Super versus infratemporal isn't quite as clear, but it does send us down a list of more likely diagnosis in most cases. In general, Infratentorial, we think in general more in the children. Supratentorial, we think more in the adult, but those are broad generalities that don't always hold true. If we consider the age, again, age by itself will be a major determinant in where we're going to go with our differential. Enhancement, the degree of both the degree of enhancement and the pattern of enhancement are often helpful in making it a differential. Presence of mass effect or edema in terms of how aggressive a lesion is or how circumscribed a lesion is. And then sometimes the peripheral location versus central location will help us with our differential. So if we begin with the astrocytomas, the most common classification now is grouping what used to be called the grade 1 and grade 2 astrocytomas together and calling them just astrocytoma or low-grade astrocytoma. The grade 3 are anaplastic, the glioblastoma, and then we're going to talk separately about pilocytic astrocytomas and a couple of more uncommon tumors, the pleomorphic xanthorastrocytoma and the giant cell. If you remember broad categories in terms of numbers, I don't think remembering 10% or 12% are important, but about 10% of primary brain tumors, kind of a generality, about 10% will be low-grade astrocytomas. This is the grade 1 and grade 2. In adults, they're generally a tumor of the cerebral hemispheres, and their peak age range is around the 30 to 40 years of age. These consist of, as I said, the grade 1 and the grade 2. The grade 1 are the circumscribed lesions, including the JPA, which we'll come to in a moment, the juvenile polycytic astrocytoma, the xanthogranuloma, and the giant cell astrocytoma. The grade 2, or diffuse tumors, include the fibrillary histology, the gemystocytic, which is very rare, and the protoplasmic. I don't have examples of the last two. The gemystocytic has a very high tendency to degenerate into anaplasia and to glioblastoma. By CT, low-grade astrocytomas are generally well-circumscribed, hypodense lesions, little or no enhancement in general. You can see some calcification, about a quarter of lesions, and you can see cystic changes, as I'll show you in a moment. Generally minimal edema and very little mass effect with these lesions. About 2/3 of them in either the frontal or temporal lobe. So these are a tumor, supratentorial, frontal, temporal lobe. And occasionally you can see a little bit of enhancement along the periphery or a little nodular enhancement, but in general, very little enhancement. They can be large, they can have cystic components, but even with this, you see relatively little surrounding edema. There's some local mass effect, but no edema-causing mass effect beyond the area of the tumor. The anaplastic astrocytoma, remember about the same number, about 10% of primary tumors. Again, temporal and frontal lobe predominance, but about 10 to 20 years older than in the low-grade astrocytomas. These have a poor prognosis, with about half of them progressing to glioblastoma within 2 years. And characteristically, these look much more aggressive. There's vasogenic edema, there's mass effect, they have a heterogeneous appearance in both CT and MR. The enhancement is variable. You can see very intense enhancement, you can see whirls of enhancement. In all these pictures, a much more aggressive looking appearance than the low grade. Here's another lesion, cystic components, enhancement, portions of the tumor. And while calcification and necrosis are uncommon, calcification certainly does happen in the anaplastic astrocytomas. Finally, the glioblastoma, about 50% of the astrocytic tumors and about 15% overall. So these are the most common of the astrocytic tumors. Throughout the brain, and in fact can occur in the posterior fossa too, although this is less common. Necrosis and hypervascularity are the histologic hallmarks, and so we need to, whether or not we see these, they will have these histologically or pathologically. Remember, glioblastomas may have CNS metastases, and they may involve the ependymal lining of the ventricles, which will be important in a moment as we talk about differential. And as you know, a dismal prognosis for glioblastomas. Again, like the anaplastic astrocytoma, a very heterogeneous appearance. Calcification uncommon, but hemorrhage is relatively common. Heterogeneous signal depending on the presence of cysts, hemorrhage, cysts and or hemorrhage. There's usually significant mass effect and edema, and there will be necrosis in all lesions, but radiographically in almost all lesions we'll see some evidence of the necrosis. This is one typical appearance with this kind of lobulated pattern of enhancement. And remember, the tumor extends beyond the area that we see abnormality here. So consider the possibility of using spectroscopy to assess the extent of tumor. But a surgical resection that takes out the enhancing tumor will miss microscopic extension beyond the confines that we see radiographically. Just more examples. In the enhanced images, we more clearly see the necrosis centrally within this tumor, the ring enhancement pattern around the area of necrosis. And glioblastomas are in our differential for lesions that will cross the corpus callosum. By and large, lesions across the corpus callosum are glioblastoma and lymphoma. When you see this aggressive heterogeneous appearance, think about glioblastoma rather than lymphoma. Lymphoma is usually a more homogeneous lesion. This kind of an aggressive pattern, even without crossing, you'd have to think about a very aggressive tumor, and glioblastoma is what we think about with very aggressive tumors. And they can be multicentric. Often when we see tumors that are multicentric in contiguous locations, in fact, there are microscopic bridges. We're seeing one tumor with little microscopic bridges from site to site. Obviously, in this case, we're seeing a true multicentric lesion with a supra and infratentorial lesions. Okay, from the very aggressive to the opposite extreme, the pilocytic astrocytomas represent very well circumscribed lesions. They grow slowly. They have very little tendency to infiltrate the surrounding parenchyma. We see them pretty much throughout the brain, but there are some classic locations. The pilocytic astrocytomas occur in the frontal lobes, in the posterior fossa in children, as we'll see when we talk about infratentorial lesions. In the optic nerve hypothalamic region, so we don't really separate optic gliomas or hypothalamic gliomas in many cases because a lesion at the level of the chiasm may be inseparable from a hypothalamic lesion. These peak supratentorially at about age 20. In the cerebellum, they peak in about age 10. And they are 60% of the 60% of them will occur in the posterior fossa, so they are more common in the posterior fossa than supratentorial. Overall, these have a good prognosis except the brainstem lesions, and again, we'll discuss those with the infratentorial tumors. In the hypothalamic region, the most common histology is juvenile pilocytic astrocytoma, although less commonly there can be a more aggressive histology in that location also, so these are not all low-grade tumors. These are primarily a tumor of children, and they may present with obstructive hydrocephalus. By CT, we see a hypodense mass in the suprasellar cistern. You can see the hydrocephalus just by the visualization of the temporal horns here. In general, heterogeneous, but predominantly high signal intensity on the T2-weighted images. And in this location, as well as in the brainstem, these lesions are usually solid, predominantly solid at least, sometimes with very small cysts associated. They also have a tendency to very marked and intense enhancement, which is one of the exceptions to our general rule that the more enhancement, the more aggressive a lesion. That's not the case in this instance. The pleomorphic xanthorhabdocytoma is a relatively uncommon tumor. I just heard a lecture where someone was saying you see 3 or 4 of these a year, and I have to say I've been looking for this tumor to put into this talk. And as I went back through the pathology at our hospital, and I found one case in the last 17 years pathologically proved. So I've got that one lesion here. I find this to be a rather uncommon tumor. Generally, this is a peripheral location, most commonly in the temporal lobe, sometimes in the frontal lobe. So that peripheral location is our first clue to this diagnosis. They arise from the subpial astrocytes, which is the reason for the peripheral location. They often present with seizures with a relatively large lesion. And the World Health Organization, this is a grade 2 lesion. This is, in fact, a tumor that had been previously resected. There are some areas of hemorrhage in here, but you can see the peripheral location and the enhancement. About half of these will have cysts, and generally the margins of these are relatively well defined, although these are relatively indolent lesions in general. Calcification and hemorrhage are uncommon, although I'm showing you the exception of the rule because, as I said, this is the only one I had. One of my colleagues gave me these 2 cases. I don't have a great deal of details about them, but the peripheral location, the intensely enhancing nodule, smaller cystic component, peripheral location. Relatively uncommon, but think about that with a large peripheral location, and obviously the juxtaposition there was the JPA would be the differential in that case. Okay, let's move on. Oligodendrogliomas. About 5% of intracranial gliomas. World Health Organization, a grade 2 lesion. Most commonly frontal or temporal white matter. They usually involve the cortex, then with secondary extension deep into the white matter. So there'll be a peripheral lesion which is extending more centrally. About 30 to 50 is the age range. 90% of these will calcify. It's the most common tumor to calcify. It's one of those trivia questions that doesn't do a lot for us because while it's the most common tumor to calcify, it's a relatively uncommon lesion. So any given lesion that you see is less likely to be an oligodendroglioma, even if you have calcification there. So it's an interesting fact, but not helpful in our differential in most cases. A large number of oligodendrogliomas, in fact, are mixed tumors. Oligodendrogliomas are mixed with astrocytes. And then there is also an anaplastic oligodendroglioma, with a much more aggressive histology and poor course. By CT scan, I have a small lesion here, generally isodense lesion. Calcifications are frequent, as we've just said. Cysts are uncommon but do occur, and hemorrhage occurs in about a third of them. When you have very large lesions, you may in fact see remodeling of the adjacent bone because, as I said, these are relatively indolent lesions and they have time to have bony remodeling or to cause bony remodeling. Calcification, if you're doing by MR, is seen best with gradient sequences, which may be somewhat helpful, but as I've just said, it's a relative thing. Calcification doesn't do a great deal for us in making a final diagnosis. Usually very little edema or mass effect. When very large lesions may have local mass effect, but no significant edema. About half to two-thirds of them will have contrast enhancement, generally peripheral, although occasionally homogeneous enhancement. And the more enhancement is worrisome for a higher grade lesion. Here's one we see best on the T2 weighted images, iso-intense in the T1, and some faint linear enhancement on the post-contrast study. And here's a much larger lesion adjacent to the ventricle, adjacent to the cortical surface. And here you can see that the epicenter we'd have to put somewhere out here with secondary extension. You can see some cystic components to this one also. And here an even larger lesion. When I've shown this case before, I've gotten people, oh, this is a glioblastoma. Well, it's a large lesion, it's heterogeneous, but there's no edema. It's very well demarcated. It has the appearance of a relatively indolent lesion despite the enormous size. There's mass effect, but it's really mass effect because of the lesion. There's no edema around it. It's just effacement of the parenchyma adjacent to the lesion. They may have very dense calcification, as in this case, and this shows very nicely our problem with intra versus extraaxial. This study on the CT, it's hard to tell whether we're looking at something pushing up from the floor of the middle cranial fossa or something intraaxial. On the MR, however, we can clearly see that we're looking at an intraaxial lesion with heavy calcification. So a differential for oligodendroglioma, and I'm going to go through brief differentials for each of these as we come to them. Basically, an astrocytoma, that last one I just showed you in the periphery, we could think about a low-grade astrocytoma. The calcifications are much less common, but it's a much more common tumor. They're usually deeper in the parenchyma. They don't occur as close to the cortex. The gangliogliomas, which we'll discuss in a moment, are usually in a younger age population, in the 15 to 20, 15 to 25-year age range, often have large cystic components, and the temporal lobe is more common than the frontal lobes we see these oligos in. And for an intraventricular tumor, neurocytoma is definitely in the differential. And in fact, that can be an impossible differential, and you may need histology to differentiate an intraventricular oligodendroglioma from a neurocytoma. So let's talk about neuronal tumors. Together, the ganglioglioma and gangliocytoma represent less than 1% of primary brain tumors. So they're uncommon tumors, but a fairly characteristic appearance, making them important for us to talk about as far as identifying them. In the ganglioglioma, there's a mix of neural and glial tissue, whereas in the gangliocytoma, it's only neural elements. These are tumors predominantly of the cerebral hemispheres, most commonly in the temporal lobe, and less commonly they can actually be seen in the cerebellum also, and I have not been able to find an example of that to show you that. Basically, a tumor with age range 10 to 30, that might be pushing it. We talk 20 or 25 is probably more common upper limit, although they certainly can occur at a later age. These are usually low-grade tumors with a long history of symptoms before diagnosis, generally a history of seizure disorder. The CT appearance is variable and depending obviously on the presence of cysts or calcifications. Some degree of calcification or cyst is present in up to half of these lesions. The enhancement may be heterogeneous and may be very intense within the solid portions of the lesion, and there may be an enhancing nodule in a primarily cystic lesion. The biologic behavior, that is the prognosis of these, is determined by the glial elements, which may have malignant degeneration. So the ganglioglioma has a possibility of malignant degeneration, whereas the gangliocytoma with no glial elements has no malignant potential. A cystic appearing lesion, when we see cystic appearing lesions on MR, they're in fact usually found to be semi-solid at surgery. Again, that's not terribly significant for our differential. It's a cystic lesion as far as we're concerned radiographically. There's no real way to tell a ganglioglioma from a gangliocytoma, and both of those should be included in our differential diagnosis for any cystic masses, particularly with calcification of the temporal lobes or the cerebellum, especially lesions that appear relatively benign, relatively indolent. Think about the possibility of these neural and glial tumors. Here's a more complex appearing lesion, the PD and T2, and pre and post contrast. You can see the areas of enhancement in the solid portions. Just from the lesion itself, you could worry about a more aggressive lesion, but again, if we look around it, if I go back, very well demarcated, no edema around it, and the only mass effect we see is the local mass effect from the lesion. So while it has an irregular and heterogeneous appearance, it has a relatively indolent appearance. In the temporal lobe, you can't see the calcification here on MR, but you can see the cysts and the pattern of enhancement, and certainly high up on our differential for this would be one of these ganglial tumors. Here's another lesion. This is actually the one I showed you the coronal of at the beginning of the talk. In contrasting it with sarcoid, you can see the high signal in the medial temporal lobe and a little focal area of homogeneous enhancement. So the enhancement pattern can vary tremendously in these lesions. And this is a gangliocytoma, which had a spontaneous hemorrhage in it. Now, I don't have the T1 images here, but this is all bright signal intensity on the T1 weighted images also. Again, no malignant potential to the gangliocytoma, whereas there is to the ganglioglioma. And the neurocytoma, the third of this category, again, a very rare tumor, less than 1% of intracranial tumors, but about 10% of intraventricular tumors. And so it's important to us because it doesn't make any difference how common a tumor is when you're looking at an example of that lesion. So intraventricular, this should be fairly high on your list. 20 to 40 year age range, almost always adjacent to the septum. Some thought that it may be arising from the septum, although that's not clear. It can be seen in the third ventricle also, making that first hypothesis seem rather difficult or untenuous. An intraventricular bubbly mass, frequent calcifications, and prominent but often heterogeneous enhancement. Here you have a little bit of a lobulated, fairly intensely enhancing lesion adjacent to the septum pellucidum. Here's a second, even larger lesion. You can see the intense enhancement, large central vessel. See that here. It's not something that's particularly described in this case. These are grade 2 lesions by the World Health Organization classifications. Primary lymphoma of the brain is about 2% of primary brain tumors, and as we all know, an increasing percentage with the increasing number of immunosuppressed patients, both due to HIV as well as due to transplant patients, malignancies, a variety of causes for immunosuppression. In general, involves the deep brain structures, but also periventricular, extending along the ependema, or meningeal. Meningeal was the classic description of primary lymphoma of the brain, although with immunosuppression now we're starting to see more of the deep brain, and these overwhelm the peripheral ones now. They can be seen in the brainstem or cerebellum, although this is an uncommon presentation as the only or as the isolated site. The spread along the ependymal surfaces is one of the classic depictions, although as I said, glioblastoma can spread along the ependymal surfaces. By and large, when we see lesions spreading along the ependema, think about lymphoma. I'll show you a picture of that. They're often bilateral, and they're usually multiple, the lesions that we do see. On CT scan, they can be isodense or they can be hyperdense. There's not too many lesions that will be hyperdense, and there's probably 3 or 4 that we're going to talk about today. So one of the things you think about in an adult with hyperdense lesion would be lymphoma, and generally with homogeneous enhancement, although in altered immune states we can have more heterogeneous patterns of enhancement, even with ring enhancement, which may confuse us with the prime differential in the immunosuppressed patients, which will be toxoplasmosis. On T2, lymphoma is relatively hypointense, generally believed to be because of the cellularity of the tumor. So in this case, you see a solid portion, in this case, a cystic portion in this patient who's had some treatment, but the solid portion is relatively hypointense. And here's a classic picture of lymphoma with the increased signal intensity lining the ependema of the ventricles. And on the post-infusion study, you can see the enhancement both lining the ependema and crossing the corpus callosum. So the glioblastoma we mentioned and the lymphoma are the ones that are going to involve the ependema and are going to cross the corpus callosum, but this is a much more homogeneous pattern than the glioblastoma, and usually is not a terrific differential dilemma. Here's another classic appearance of lymphoma in the deep brain structures with a isointense on T1 and homogeneous enhancement on the post-contrast study. Remember that some of these patients are on steroid therapy, and that may mask the degree of enhancement. So not seeing this intense homogeneous enhancement should not steer us far away from lymphoma, especially in a patient on steroid therapy. And then here's one with multiple deep brain locations as well as 2 ependymal focal areas of enhancement, also lymphoma. Okay, so we already talked about glioblastoma, a more heterogeneous appearance. Hemorrhage and necrosis are very uncommon with lymphoma, should make you think about glioblastoma, although again, a treated lesion may make it more difficult. Treated lesion, presumably they already have a diagnosis though, and so again, other than those unnatural circumstances of being examined, you shouldn't have that dilemma. Toxoplasmosis are usually multiple, that's it plus minus, because lymphoma are often multiple too. The subependymal spread basically doesn't happen with toxoplasmosis. If you have that in an immunosuppressed patient, you're talking about lymphoma, not toxo. But again, as we know, this is a difficult diagnosis, and toxo and lymphoma are going to be in the differential one for the other in almost every case. Multiple sclerosis can have a similar appearance with these deep brain lesions with enhancement, but there's usually some mass effect in lymphoma, and multiple sclerosis really won't have mass effect around the lesions. We look for other evidence, more characteristic evidence of multiple sclerosis. Looking for paraventricular lesions will help us in making that differential. And remember, in these immunosuppressed patients, infection and neoplasm may be present in the same patient, so it's not always, is it toxo or is it lymphoma? They can have both. The choroid plexus papilloma, again, relatively rare primary brain tumor, although it does make up 2 to 4% of the primary tumors in children. Makes up an even larger percentage of the tumors in the less than 1 year of age. Overall, 80% of these will be less than 5 years of age. So this is, again, a tumor of children by and large. When it occurs in children, the most common location is in the trigone of the lateral ventricles, and for what nobody knows what reason, more often left than right. When you do see it in adults, in the cerebellopontine angle, and in the fourth ventricle, the most common locations. It may cause ventriculomegaly due to CSF overproduction or to obstruction, and which is the predominant cause is, again, open for debate and controversy. When you see extension into the adjacent brain parenchyma, you have to think about the possibility of a degeneration into carcinoma or choroid plexus carcinoma. By CT, generally a hyperdense lesion due to the frequent calcification and or hemorrhage that can occur in the lesion, calcification in about 1/4 of the lesions. Here's a classic location in the atrium of the ventricle with the enhancement of the solid portion, this one with a cystic portion also. And the signal intensity that we see will vary depending on the presence of the calcium and or hemorrhage in the lesion. So our differential for choroid plexus papillomas, the neurocytoma, generally seen in older patients. These are 80% less than 5. The neurocytoma is a 10 to 20, 10 to 25-year age range. The neurocytoma is usually contiguous with the septum pellucidum. It's not a common location for choroid plexus papilloma. Meningiomas and metastases are generally a significantly older age range. And the ependymoma in children, we'll come to in a moment, are usually an infratentorial lesion, although in adults, in those 20% that we can see in adults, this may be a difficult differential diagnosis. I'm sorry, I'm going to come to the ependymomas when we talk about the infratentorial lesions. We'll come back to those. Remember metastases. It's one that's very difficult to remember when you're coming out, when you're cramming yourself with differentials for brain tumors. Remember metastases all the time. Up to 30, maybe 40% of intracranial neoplasms in an adult. Lung and breast together probably make up 80% of those. Remember our list of hemorrhagic metastases, the choriocarcinoma, melanoma, renal, and thyroid. The CT and MR appearance will vary tremendously depending upon the calcification, hemorrhage, and multiple lesions are probably our most significant finding. Seeing a solitary metastatic lesion is one of the difficult dilemmas in differential diagnosis. And I just put a couple of lesions in here to kind of differentiate. Relatively indolent. There's a couple of lesions here on the T2. You see that there's several more in the contrast. Obviously, frequently the contrast will show more lesions than we see in any other imaging sequence. They can be relatively indolent appearing. I have 2 lesions here, very little surrounding edema, very little mass effect. This is lung cancer, metastatic lung cancer, no enhancement in that one. And anytime with multiple lesions, consider the possibility of metastases. The appearance can be tremendously variable. The degree of enhancement, the degree of edema, the appearance of the lesions, very difficult to differentiate these.